Dr. Josh Chacko, we will
Yes,
move
Jaicob.
to our next second question, which we go on to a different set of patients. Managing a neuro-intensive care patient for a neurological issues is always a challenge for clinicians, especially in the ICU. And with ultrasonography being utilized in each and every aspect, the challenge of managing or monitoring an ICP is always something which which affects patient care in neurosurgical patients. So, is neurosonography a viable substitute for invasive intracranial pressure monitoring?
Thanks, Jacob. You raised a very relevant question indeed, because I don't know about others, but most of the ICUs that I worked in India, the practice is not to measure invasive pressures in neurosurgical patients, as in intracranial pressure monitoring. Like, for instance, the general practice across the world in most of the advanced neurosurgical centers is to use intraparenchymal monitoring to measure ICP. And almost all patients who have severe traumatic brain injury particularly will be on ICP monitoring if they're on ventilation, sedation, paralysis, because it's very crucial to do so. There is no other clinical methodology by which you can assess their neurological well-being in patients who are sedated, paralyzed perhaps, on ventilation for an extended duration of time. And you can't do CT scans so many times. There is a limit to the number of CTs that you can do. And that's why ICP monitoring has become such an important tool in the routine monitoring of these patients. Although clinical studies have not really established the outcome benefit related to ICP monitoring, it still remains a logical tool in the monitoring of patients who are sedated, ventilated with severe, particularly traumatic brain injury in ICU. So if you do not have access to invasive pressure monitoring, as in intraparenchymal or intraventricular, what are the options do you have? One of the ready options that comes to mind is the use of ultrasonography. The use of ultrasonography to measure intracranial pressure is based on measurement of the optic nerve sheath diameter. It is based on the concept that the optic nerve sheath is a continuation of the brain itself, and it includes the meningeal layers. The optic nerve carries with it the meningeal layers as it comes out of the brain and essentially remains a part of the brain. And as the ICP rises, the optic nerve sheath also distends almost in real time, hand in hand with the rise in intracranial pressure. So, if you have bedside ultrasound, it is relatively simple to look at the optic nerve sheath through ultrasonography by the bedside, although there are several artifacts which we will briefly discuss a little later on. So if you can measure the optic nerve sheath diameter, it will perhaps be a reflection of the intracranial pressure and help you assess your patients, particularly those with severe traumatic brain injury who may be sedated, ventilated, and cannot be assessed readily. If you go by the pupillary signs, for instance, if you look for a dilated pupil, it'll be too late by the time you recognize it, and the battle would have been already lost. So that's why ultrasonography may be such a useful tool by the bedside. There are a few important points to remember when you do that. First is, of course, the use of the probe, the choice of the probe. You would use the linear high-frequency probe to look at the optic nerve sheath. And second is, how do you measure it? What is the exact location of measurement? It is 3 millimeters from the posterior wall of the globe, and you need to measure from the outermost point to the outermost point of the sheath itself. There is usually a hypoechoic artifact just around the sheath, which you should not include in your measurement. If you include that, it might still correlate, but then you will get falsely high values. So it's not really recommended to include the hypoechoic area that surrounds the sheath. And most importantly, the question also arises as to what is the cutoff for a rise in intracranial pressure. There have been several studies, all observational of course, which have looked at cutoff limits for the optic nerve sheath diameter. And people have pointed out that some of these studies have actually measured the diameter wrongly, as I pointed out, including the hypoechoic artifact around the sheath, which will make it falsely high. So there is a question about that as well. But if you measure it correctly, the cutoff is generally between 5.7 to 5.8 millimeters, 3 millimeters behind the posterior edge of the globe. So that's where you measure. Roughly 5.7 is a ballpark number that you can go by. So does this actually mean a lot in terms of raised ICP? And would you act purely based on this level of ICP? The simple answer is no, you wouldn't. You need to consider it as an indicator of raised ICP, but you shouldn't, of course, go entirely by the optic nerve sheath diameter. Obviously, you will have a look at the CT scan to see if it really confirms the rise in ICP that the optic nerve sheath diameter seems to reflect. And for that reason, it should not be taken as a single isolated number. You should look at the trend over time. A single number does not really mean very much. What I would suggest and what we also follow in our unit is to measure a baseline optic nerve sheath diameter. And you will have a CT scan, of course, to correlate with that level of sheath diameter. And then you do it periodically, once every couple of hours. It is preferable to have the same operator do it. Of course, it may not be practicable. But you go by the trend, and if at all you suspect an increase in the diameter, it would be a pointer that maybe the ICP is rising, and maybe you would get another CT scan done. So it can only be an indicator that the ICP may be rising. You would obviously require imaging as well to confirm any significant deterioration in the neurological status.
Thank you so much for highlighting the importance of ICP monitoring in neurocritically ill patients. The reluctance and the lack of expertise is always an issue. So optic nerve sheath diameter, as rightly pointed out, can be an option, at least to give the trend, and you go on the next step of evaluation. Thank you, sir.
Thanks, Jacob.